So I'm going to give two talks. The first one is about acute coronary syndrome with non-significant lesion, the vulnerable plaque paradigm. So this is a really interesting topic. I have no disclosures for this talk. This is what I'm going to talk about. How has our thinking evolved over the years when you think about the etiology of myocardial infarction? We take care of myocardial infarctions every day, but do we really know what causes it? Is it just about coronary artery thrombosis? Is that what we think because that's what we learned? Or is there something more? What about this vulnerable plaque issue? Do we define it this rupture-prone, event-prone plaque? Have we really advanced our understanding dramatically in the 2 decades? The answer is yes, and I'm going to talk to you about that. What has been our evolution in the thinking about the vulnerable plaque paradigm? So I think this was very interesting, and I thank the organizers for asking me to give this talk. So what has been the traditional thinking? The traditional thinking is that the degree of arterial narrowing is directly proportional to the risk of myocardial infarction, right? I'm an interventional cardiologist, and I always thought if you have a 70, 80, 90% lesion, you've got to fix it. Why? Because that's what causes myocardial infarction. That's what the patients think. That's what everybody thinks. But the question was, how do we know that? And the early days, they said that that was related because they did MI and stroke studies, cohort studies, and they related the stenosis to myocardial infarction. And that's where that traditional thinking came from. So if you think about it, we always thought about stenotic lesions leading to ischemia, so we did a stent, particularly as an interventionalist. But what we have learned, Libby and his colleagues, as far back as 2005, showed that non-stenotic lesions that were lipid-rich, that had a thin cap, really can cause infarctions also. And that started to change our thinking a little bit. So here is a CT angiogram. And if you look at panel B there, this panel B right here, what you see is positive remodeling. You see that little shelf there? And low attenuation plaque, spotty calcification there. And those were detected in a CT angiogram 6 months before the patient had an acute coronary syndrome event. But you would read this CT angiogram as not having any significant stenosis, right? So interestingly, this person ended up having acute coronary syndrome. Now, why is that? If the thought is that it's because of a significant stenosis, why did this person have? Because of some of those things, the low attenuation plaque, the positive remodeling, the spotty calcification. Now here's Dr. Motomiya and his colleagues in 2009 went ahead and looked at over 1,000 patients with CT angiograms. And they looked at over 10,000 coronary segments. And what they found was there were 2 positive features. One was positive remodeling and low attenuation plaques. And what they found was that these 2 features, if the patients had these 2 features, they did worse. So if you look at the panel, 2 features negative. So if they didn't have anything, the cumulative event-free rate was that. But if they had 1 positive plaque, then they did worse. But if they had 2 positive plaque features, they didn't do as well. So already we're starting to think that maybe there's something more than just stenosis. Maybe it has to do with this vulnerable plaque issue. Now, here's the same, Dr. Miyamoto showed us further that if you look at the event-free rate, these low attenuation, which is less than 30 Hounsfield units, or a positive remodeled plaque, if you see those right here, those patients were considered high-risk plaques. So again, the number of events, the event rates were higher if they had those features. So it made you start thinking. So these studies evolved our thinking. The nature of plaque, rather than the degree of stenosis, may predict progression of plaque rupture. Okay, so now that's where we are, and these are characteristics of invasive and non-invasive testing or imaging that you can do to detect high vulnerable plaques. So of course, I already mentioned to you CT angiogram, then we have IVUS, we have OCT. Those are the main ways that we characterize plaque and look for these features. And keep that in mind. Again, in this particular panel that showed some images, this was looking at plaque regression. And what they saw was that IVUS showed us the plaque, but then you see some follow-up, some plaque regression, less plaque OCT also shows plaque regression. If you look at the luminal size, it's much larger. So these are the modalities that we're using to look at that. But what about CT angiogram? Because this is important. We're doing this. Contemporarily, we're doing CT angiograms, so we need to know. Positive remodeling that I told you about. See this little shelf right here? The increased outer diameter, this is positive remodeling. The napkin ring sign that they talk about, the so-called napkin ring sign, the spotty calcification, and then the low attenuation plaque, because of the fact that you have a lipid-rich plaque there. And that's where those are the features that you want to look at when you look at a CT angiogram to know if somebody has a vulnerable plaque. Now, this is an image where they showed pathologic slides, and what they saw was plaque rupture, plaque erosion, calcified nodules, and then they showed what it looks like on OCT. So OCT is actually a very, I do a lot of IVUS, I don't do as much OCT, but OCT is an excellent way to look for this vulnerable plaque. Well, then you have Mark Dwight out of England, who has been doing a lot of research on PET, and what he found was that maybe we can use PET findings as a way to correlate also for these vulnerable plaques. And what he looked at, and what his group looked at, was this LAD with low attenuation plaque, and then again, the spotty calcification. So once again, we're starting to move away just from anatomical findings to something that shows us if there's ischemia. So again, our thinking is shifting a little with this, the PET findings. So maybe the nature of the plaque rather than the degree of stenosis may predict progression to plaque rupture. So the first question is, does plaque rupture really cause myocardial infarction? Is that what happens? So let's look at that. So if you look at an autopsy series, what you find is that subclinical episodes of plaque disruption followed by healing are the stimulus of plaque growth. So the only way a plaque grows is that you have all of these subclinical episodes of plaque disruption. And this can occur suddenly, and it is the major cause for high-grade coronary stenosis. And this mechanism would then explain the phasic rather than linear progression of coronary disease that we see on angiograms. If you did angiograms on a yearly basis, you may see this. So keep this in mind as we talk further. So plaque rupture then leads to plaque growth. Thus, plaque rupture is a common phenomena that only rarely leads to myocardial infarction. So going back to that question, was it plaque rupture that caused a myocardial infarction? Well, based on this explanation, we have a lot of times when we have plaque disruption, but that doesn't always lead to myocardial infarction. So more questions. So I answered the first question, does plaque rupture cause myocardial infarction? I just told you, it rarely leads to myocardial infarction. So second question, does identification of vulnerable plaque outperform quantification of plaque burden? So what do you think the answer is here? Just curious, anybody? Yes, okay, the answer is yes, let's find out. So here is a study that they published in 2018 that looked at the association of intravascular ultrasound-derived lesion characteristic. And what they found was that if you had thin plaque atheroma, okay, and the red is absent, the blue is present, it didn't make any difference in terms of how. So presence of thin cap atheroma, which we would hypothesize would lead to higher events, but it didn't. It didn't. But look at the next one, plaque burden, okay? If the plaque burden was absent, they did better, but they didn't do as well when they had a huge amount of plaque burden. So it did show plaque burden greater than 70% causes events. So then, is there a way to screen the population with a less expensive test? Imagine if you believe that it's vulnerable plaque. That means we would have to do IVUS and OCT on everybody. Do you think we could do that? Probably not. Is that really feasible at a population level? Not really. So is there a way we can do that? Well, if this study is true and it's about the plaque burden, then maybe coronary calcification score is maybe the way to go, and that's what we should be thinking about because it predicts outcomes. So here's the MESA study that looked at multiple different ethnicities, and it looked at the amount of calcified plaque does predict the incidence of coronary events. The amount of calcified plaque is a predictor of future events. So in this panel, the blue right here is if the calcium score is over 300. The yellow is 0. So if you look at the cumulative incidence of major coronary events, the events go up as the calcium score goes up. The same thing with the cumulative incidence of coronary events here if the calcium score is high. So I think that the amount of calcified plaque is a true predictor of future events. So quantification of plaque burden therefore identifies at-risk patients. So we can use coronary calcification, which is obviously an easier and a cheaper test for us to do at a population level. So more questions. Does treating vulnerable plaque reduce cardiovascular death? You know, if we're worried about vulnerable plaque, does that make a difference? Well, there have been no double-blind, placebo-controlled, randomized controlled trials focused on treating vulnerable plaque rather than plaque burden. All of the studies that we've ever done is about plaque burden, never just about vulnerable plaque. So this is what I call an evidence-free zone. We don't know the answer. The ischemia trial looked at revascularization in coronary disease, does not reduce all-cause mortality. And why is that? Well, maybe because there were patients that, you know, it's a little bit about plaque burden, but is it about the vulnerable plaque? So let's look at the Scott Hart. How do we explain improved outcomes with coronary CTA versus standard care? Is it because they identified vulnerable plaque, or is that why we had improvement? So maybe when they saw the higher calcium score, maybe that is a way to predict some of this vulnerable plaque, and maybe they had improvement. So in this particular study, you had standard care versus CTA, and look at how much better the CTA population did. Death from coronary heart disease or non-fatal myocardial infarction, and those patients did better. So I know I'm running out of time. So CTA improves coronary heart disease outcomes, enabling better treatment. So in this study, this is an elegant study that showed that patients that had not even any angina, but if they had a high calcium score, we started giving them more change in their treatment in terms of statin therapy and all of that. So I think we can change the outcomes by being more aggressive with those patients that have a higher calcium score. And maybe that's what's making a difference in how these patients do. So I think this is the change in the concept of coronary artery disease between 1980 and 2022. I think we started off with the coronary artery stenosis, then we talked about vulnerable plaque, then we started talking about inflammation and about imaging and how that can help us. And so I think that we have gone from a vulnerable plaque discussion to a vulnerable patient discussion. So it's not about vulnerable plaque, it's about the vulnerable patient. And ultimately, the concept of vulnerable plaque, the patient is a combination of if they're prothrombotic, if there's an elevated total atheroma burden, and the disease activity. So this is about the vulnerability, this is about the total burden, and then the prothrombotic state. And that is what then talks to us about the total risk of ACS. So again, I don't have time to go into this, but there's a lot of things that can increase the risk of coronary events. And so when you look at the guidelines, where are we today? Interestingly, what you see is CTA, total plaque burden, high-risk plaque features, low attenuation, reduced CT fraction flow reserve. So this is where we are. So we do talk about plaque burden and not just vulnerable plaque. And so when we talk about this, what we are looking at is all of these patients need high-intensity statin, and we're really talking about lifestyle changes in these patients. So the vulnerable plaque concept originated from human pathology studies that led to remarkable advancement in our understanding, but our thinking has evolved. We think of the vulnerable patient or populations and recognize that the vulnerable plaque and the plaque burden, as well as inflammation, all of those make up that vulnerable patient. We know to date that comprehensive risk assessment needs to be performed to identify these patients at risk, and the foundation of guideline-based therapy is to intensify preventative therapy in patients with established plaque burden. So developments of invasive, non-invasive coronary imaging has helped us to detect patients that are rupture-prone, vulnerable plaque characteristics. So I think in combination with risk factors, plaque imaging might provide us an accurate picture of an individual's risk. So I'm going to stop here, and I hopefully I've answered the question about the plaque, the vulnerable plaque paradigm. So thank you very much. All right, so my next talk is about acute coronary syndrome again, but this time in patients that have non-obstructive coronary disease. You know, you see this in women, right? They come in and they have either a myocardial infarction or they have a non-STEMI. You take them to the cath lab and you say, oh, you're fine, your coronaries are normal. Is that the right answer? That's what I want you to think about. Because I will tell you that the answer is, so the title of the talk is ACS with normal angiogram. Should we care about microcirculation assessment? And particularly for, so this is important for all of us, but all of those interventionalists. Again, no disclosures. So coronary artery disease, of course, is a disease of major epicardial vessels. But what we tend to do in the cath lab is to ignore the microvascular dysfunction. We don't even think about the microvasculature in a patient. But if you go back, I'm gonna go back and just show you my first slide. Look at all of the microvasculature in that picture on the right-hand side. It's dense with microvasculature, but we don't think about that. So in patients presented with acute coronary syndrome, 6 to 10% of myocardial infarction patients and 10 to 25% of those without a myocardial infarction have normal or near normal coronary arteries at angiogram. That's not a trivial number of people. Think about how many times you've taken an MI patient, an acute coronary syndrome patient, and they've had completely normal coronary arteries on angiogram. Okay, but this is where performing an invasive functional assessment may have important prognostic and therapeutic implications, and that's what I'm going to talk to you about. And I want you to think about two concepts: INOCA, which is myocardial infarction with non-obstructive coronary arteries, and MINOCA, myocardial infarction with non-obstructive coronary artery disease, because these are the two entities we talk about, INOCA and MINOCA. And so the reason it's important for us to have this discussion is that if you understand this, then you can tailor the patient management and you can improve their symptoms as well as their prognosis. Because these are the patients that are gonna keep coming back to you and say they have chest pain. And you're gonna get frustrated and say, but your angiogram is normal. Well, of course their angiogram is normal because you didn't bother to look at the rest of the heart, which is the microvascular. So this is a nice figure that shows myocardial infarction with non-obstructive coronary disease. And what I want you to focus on is two things: the epicardial causes, and this is the plaque disruption, the spasm, the coronary artery dissection, and how we image that. But there's also microvascular causes. And these are what I want you to think about: myocarditis, coronary thromboembolism, Takotsubo's, and we're going to talk about some of these in detail. So when I talk about the microvascular, what am I talking about? Well, the epicardial vessels, which are over 400 micrometers, we talk about those, but we're talking about the small artery, we're talking about the arterioles, and we're talking about the capillaries. And these are endothelial dependent, vascular smooth muscle receptors are here, and these are regulated by metabolic activity. So very, very different response. And this is where we use FFR, but we have to use other measures here to be able to take a look at those. So again, we're talking about a slightly different area, and there are many conventional and novel methods to look at the coronary microcirculation. And so there's angiographic no flow, but there's the flow and flow wire. There's also cardiac MR. So we're going to take a look at that, and then if you're in the angiogram, you're going to do pressure measurements and flow measurements. So coronary microvascular dysfunction, coronary endothelial dysfunction, and epicardial vasospasm can determine myocardial ischemia or even infarction in the absence of flow-limiting epicardial coronary stenosis. And that's all you need to know, because you've already just answered the question that I asked at the beginning. Should we ignore this? No, we shouldn't. So when you have a patient that comes in, they have acute coronary syndrome, you're going to start with an angiogram, and you're going to rule out Takotsubo's, right? You're going to do an LV-gram, you're going to see that they have typical Takotsubo's, so you're going to stop. But if not, then you're going to go on. You're going to do, usually we do an MR or CT. Some places only do CTs, they don't have MRs. And then they rule out things like myocarditis. But they can also do intravascular imaging to look for plaque rupture, spontaneous coronary artery dissection, myocardial bridging. And then if you're in the lab and you've ruled out everything else with the MR, with the intravascular imaging, then you're thinking about vascular reactivity testing. This is where you're going to test the microvascular dysfunction. You're going to look at the quantitative functional assessment, and you're going to look at the index of microvascular resistance, and you're going to look at the hyperemic microvascular resistance. So the index, the IMR, you're going to do by thermodilution-derived pressure wire, and you're going to do the hyperemic microvascular resistance with a Doppler pressure wire. And so what's the evidence for doing this? Well, the core micro trial demonstrated that performing an invasive functional assessment in INOCA patients can help you to decide what type, specific endotype of INOCA you have. See, it's getting more complicated, right? It's not just about INOCA and MINOCA. Now you've got INOCA with all these different endotypes. But if you do that, then you can tailor your medical therapy and have significant improvement and reduction in angina severity and quality of life. So the bottom line is, in a patient with signs and symptoms of myocardial ischemia without angiographic evidence of obstructive coronary disease, coronary angiogram should be considered incomplete without doing coronary vascular dysfunction workup. So there are many studies that look at this. I know I have limited time. I didn't realize I had so little time. So this is the cath lab interventional protocol. And in the most recent ESC guidelines, there's actually recommendations for what we should do class 2A or 2B, depending on what you're going to do. But there is a protocol to do acetylcholine as well as adenosine challenge to look for this. And if you do that, a comprehensive functional study, it looks not only at coronary function testing, but a provocative test. It will help us to identify those endotypes that I was talking about. And this slide shows some of the endotypes. You can have microvascular angina. You can have vasospastic angina. You can have both microvascular and vasospastic angina. Or lastly, you can have non-cardiac chest pain. But this is how you know when the evidence is there. And so it's important for us to think about that, because it then can help us to decide. So if you have functional coronary microvascular disease, it's associated with increased risk of hospitalizations with recurrent angina. If you have a structural CMD type, these patients have more increased risk of acute coronary syndrome and death, mortality. So, and then treatment is based on that. Traditional cardiovascular risk factors all contribute to coronary microvascular and vasospastic dysfunction. So here's another study that says we have to be very, very aggressive with traditional risk factor. Hypertension has been strongly associated with adverse remodeling, and I think that we need to be very aggressive with treating the traditional risk factors, because not only does it help with epicardial vessels, but it helps with microvascular disease. So MINOCA also accounts for 6 to 8% of patients presenting with acute myocardial infarction. And of course, there are many, you have to rule out sepsis, pulmonary embolism, tachyarrhythmias, myocarditis, and Takotsubo's in these patients. But again, there are many things that can result in MINOCA: plaque rupture, erosion, SCAD, microvascular spasm, and coronary embolism. So when you look at a whole workup, you look at the patients come in with a STEMI. If they have a STEMI, then they have an angiogram. If the angiogram has obstruction, then of course you treat them. If they have no significant obstruction, then they go on to having an MRI, and then look to see if they have ischemic or non-ischemic. Then you can do IVUS or OCT, a provocative test. Look for Takotsubo's myocarditis. And then, of course, you do other workups. So I think there's a whole algorithm that you want to follow. But the things you think about when you think about MINOCA: coronary artery disruption, coronary artery dissection, coronary artery spasm, thromboembolism and myocarditis, as well as Takotsubo's. So the next few slides are just pictures. So the top panel you can see is Takotsubo's, 2 different versions of Takotsubo's. This patient has a myocardial bridge, actually, and this one was considered a normal angiogram. And if you look here, this is a MRI that shows enhanced cardiac, subendocardial enhancement, and that of the lateral wall in MINOCA with acute myocarditis. So this is a patient with myocarditis. This is a patient that had reactivity testing, and what you found was here is that this patient right here had proximal spasm with giving them methadone in this case, and then they had significant spasm. They received nitroglycerin and they got better. So look at the initial angiogram. If you stopped right at the angiogram, wow, this is a normal angiogram. But look at what happened to this patient. And this is a patient that kept coming back with recurrent angina. And when you did the provocative test, you proved that the patient had something more. So here's another example of a patient, 55 years old, that presented with sudden onset of chest pain for 2 hours. And they did an angiogram. and the angiogram showed no significant stenosis. The ventriculogram was normal, so you've ruled out Takashobus. And now you go on and say, okay, what else do I need to do? They did an MRI, and what they found was the final diagnosis ended up being anterior subendocardial myocardial infarction. But if you didn't stop here, you would have gone on to the IVUS imaging, and then you would have done the provocative testing. That's what I want you to think about. So microvascular plays an important role in the flow regulation and metabolic regulation, and I think should be considered in every patient that has persistent angina and ongoing ischemia and no obstructive coronary disease. I don't think in today's day you can just stop when they have normal coronaries but they have classic symptoms. And I think that if you recognize this, there's considerable risk of adverse cardiovascular events in these patients, including heart failure, myocardial infarction, stroke, and death. So I think an invasive assessment of the microvascular is important in patients with acute coronary syndrome and non-obstructive coronary artery disease. So I'm going to stop here. Hopefully I didn't go over too much. Thank you so much.